Hi, my name is Dr. Shweta Gupta. I'm Clinical Director at Medicover Fertility, Delhi. Today, I'm going to speak on role of anti-Mullerian hormone in infertility. As we all know, with recent and medical advances, life expectancy has now moved up to 80 years. But unfortunately, fertility life still ends at 40. And that is because as the women age increases, their ovarian reserve diminishes. Both the rates of spontaneous and assisted reproductive technology pregnancies decreases. Therefore, assessment of ovarian response potential is important before any treatment program is made. Traditionally, age and day 3 FSH have been used in the past, but nowadays, a lot of studies have reported use of antral follicle count and AMH in predicting ovarian response. So what is AMH? AMH is a 140 kDa disulfide homodimer glycoprotein and a member of the transforming growth factor in superfamily of growth and differentiation factors. The specific expression pattern of AMH is in growing non-selected follicles. And this prompted scientists to investigate whether serum AMH levels are indicative of this primordial follicle growth. Now, the number of primordial follicles is indirectly reflected by the number of growing follicles. So AMH is expressed by growing follicles up to selection and can be detected in serum. So it's a promising candidate in ovarian reserve testing. Now, if we look into this diagram, AMH is produced by early stages of follicle development, which is characterized by gonadotropin independent. So it is not dependent on the on the gonadotropins. But if we see other markers like estradiol and inhibin, they are actually produced by follicles at a later stages of development and where growth is FSH hormone dependent. So if we look into the AMH action in the ovary, AMH is produced by small growing primary and preantral follicles in the postnatal ovary. It inhibits initial follicle recruitment. This is the number 1 point, and also inhibits the follicle stimulating hormone dependent growth and selection of preantral and small antral follicles. So if we look into the conditions like PCOS, where the AMH level is very high, and it is seen that it is associated with abnormalities of early folliculogenesis within the complex PCOS pathogenesis. So how do we define ovarian aging? Ovarian aging can be defined as a period in which there is measurable decline in the levels of circulating AMH, and along with that, there is a rise of FSH and estradiol levels in the blood. AMH increases up to the age of 24.5 years and afterwards decreases until menopause. So AMH levels in blood drop yearly by approximately 0.3 microgram per liter. And these are the levels of the AMH. And there are different units and we can convert from one unit to another. So there are other biomarkers also which can be used for ovarian reserve. There is some factors in the history like age. Age is considered to be the single most important factor in determining quality and quantity of ovarian reserve. Menstrual pattern. The cycle length is supposed to be primarily determined by the rate and the quality of follicular growth and thus the duration of follicular phase. There are some endocrine static marker like day 3 FSH or inhibin B. There are some endocrine dynamic tests like clomiphene citrate challenge test and exogenous FSH ovarian reserve testing, where we give these medications and see how the patients respond. There are some ultrasonographic markers like antral follicle count. So ultrasonographic AFC count has been shown to be an excellent predictor of ovarian reserve and response within significant superiority in relation to other markers. Ovarian blood flow, which can be checked with the Doppler on ultrasound. So how do we assay AMH? There are different AMH assays, and they have evolved over a period of time. Different commercial ELISA kits are used to measure AMH, which differed in antibody pairs, standard curve ranges, and limits of detection. The first kit was introduced in 1999 by Immunotech Company, and Immunotech Company assay uses a monoclonal antibody pair, one directed at the pro region and the other at the mature region. There is second AMH kit, which was launched in 2003 by Diagnostic Systems Lab. And in this, both monoclonal antibodies were directed at the mature region to minimize proteolysis. So the IoT assay produced AMH concentrations 40% higher as compared with DSL, rendering the combined analysis of trials employing different assays problematic. Then came Beckman Coulter developed a second generation AMH ELISA kit. So recently, two commercially available AMH ELISA kits have been developed by AMH Labs. And these two kits use the same monoclonal antibody pair directed against specific linear epitopes in the stable pro region and mature region of the associated form of human recombinant AMH, and appear to have high accuracy in initial testing. So ultra-sensitive AMH ELISA kit was released in 2012, and PICO AMH ELISA kit was released in 2013. So there are different AMH assays, and they have different significance and different level of detection, and by different manufacturers. So at present, there are 3 fully automated immunoassays which are available on the market that have high specificity and sensitivity. Elexis AMH from Roche, AMH ELISA from AMH Labs, Access AMH from Beckman Coulter. So in this study, which is quite recent, in March 2021, they compared the performance of 2 AMH assays, Beckman Coulter assay and AMH PICO AMH assay. And they demonstrated that despite the high correlation between 2 commercially available AMH assays, the assay performed in a discordant manner at high and low concentration. So result of these assays are not interchangeable, highlighting the need to establish specific reference limits for individual assays to guide clinical decision-making, and the challenge of establishing future universal cutoffs for analysis. So international standardization is needed. And the difficulty in measuring AMH serum level is that there is still no international generally accepted standard for sample preparation, storage, and AMH assay. The more pronounced use of AMH is mainly obstructed by unreliable diagnostics, which is caused by lack of international standardization of AMH assay, which lowers the specificity of the measurements and clinical use. Thus, international standardization is the most important issue that should be tackled in near future. So in August 2020, Ferguson presented this paper which says about establishment of a WHO reference range for AMH. And it was agreed that by the WHO Expert Committee on Biological Standardization to establish 16 by 190 as a WHO reference reagent for AMH with a content defined by consensus immunoassay of 489 nanogram per ampoule. So there's a lot of work going on for the standardization of AMH. But if we look into some of the advantages of AMH over other biomarkers of ovarian reserve, evidence so far suggests that AMH is the best currently available test in terms of sensitivity and specificity. It is the earliest marker to change with age. least intracycle variability, randomly measured during the cycle. Ovarian reserve testing by AMH may prove to be of distinct clinical benefit in fecundity and menopause prediction in general population, prediction of pregnancy changes in couples presenting with infertility, and patient management in IVF. So in this meta-analysis, it showed that AMH has at least the same level of accuracy and clinical value for the prediction of poor response and non-pregnancy as antral follicle count. And the test optimization showed that for clinical application, the results are more promising for AMH. So in this study, the serum AMH levels as a predictor of ovarian response and IVF, they found that for poor response, the sensitivity is 74% and specificity 87%. For hyper response, the cutoff was 3.55 with a sensitivity of 94% and specificity 81%. So if we look into this study, which was by Zamil et al., AMH was compared with FSH hormone, FSH levels, and what they found that in comparison with the female's age and FSH, AMH is superior in it improves the estimation of baseline ovarian reserve. It is also helpful in standardizing the dose for optimum response and avoiding the risk of failure to retrieve oocyte or inappropriate stimulation. There is another study, which is actually from our center, where the AMH is correlated with the oocyte quality. And it was found that AMH seems to be a better predictor of quality of oocytes and subsequently embryo development in older age group when compared to the younger age group. Normal AMH level is a better predictor of ovarian reserve. Along with this, it may be helpful to predict for oocyte quality and embryo development in older women undergoing IVF. The very important advantage of AMH is it appears to be stable throughout the cycle. This was presented by Lamarca et al. In 2006. But then there are a lot of factors which can influence the AMH levels. And if we look into this chart, there are some factors which are physiological, like the menstrual cycle, age, or pathophysiological, like granulosa cell tumor, or non-physiological, like when we administer hormones like oral contraceptive pills or ovarian stimulation. There can be problem in AMH pre-analytic variations like freezing, the tube type, the stabilizing reagents, and also the temperature variations for the sample, physical handling of the sample, contamination, hemolysis, and how we assay the AMH, the antibody specific and sensitivity, or there could be a lot-to-lot variability between the samples. There is uncertainty and inter-assay variations. So even though we say the levels remain stable, some studies have shown that the levels are higher during the follicular phase than the luteal phase. And since highest AMH levels are demonstrated in the follicular phase, the optimal time to measure AMH concentration might be during the follicular phase. And this was the very famous study by Gorkam et al., where you can see that the follicular phase, the AMH level is higher than the luteal. But in spite of that, it is seen that this variation is not much clinically significant. Then do we expect some changes in the levels because of the ethnicity? And this is very important because most of our textbooks or our literature comes from Caucasian or the Western population. Then should we be using that for our Indian or Asian population? In this study, which was done by Mr. Goody Group from London, what they found that in their clinic, there was no independent association of ethnicity and serum AMH levels in an unselected population of women attending the Fertility London Clinic. But then another study, which is by Banker et al., where they found that ethnicity is an independent predictor And when they compared with the Caucasian population, Indian women had lower implantation rate, and ongoing pregnancy rate was much lower as compared with Caucasian women. And they said that ethnicity, like age, is a major and independent predictor of IVF outcome. So this paper, which was published recently in February 2021, there was this variations according to ethnicity, race, may be dependent on additional factors like BMI, PCOS, socioeconomic, environmental, nutritional, vitamin D. And they said age is a strong common denominator that influences the reproductive life of women, regardless of race or origin. Caucasian women are often the reference standard when we assess the ethnic differences for a variety of parameters in infertility, and they found that the AMH was 25% lower in Black women compared to Caucasian women, which was independent of age, BMI, smoking, HIV. The Chinese were compared, and what they found that AMH levels were typically higher in Chinese women up to age of 25 years, and then AMH levels tend to be less than Caucasian women after age 25. So this study by Nelson et al., when they compared European and Chinese, they found that AMH was 28% lower in Chinese population at age 30, and this declined increased to 79.4% at age of 45. And there were independent effects of age and ethnicity on serum AMH concentration, with Chinese women having a substantially lower AMH in adult life than their European counterparts from age 25 onwards. Now, what effect environment has on the AMH level? So let's see a few studies. This is a study by Lamarca, where they checked the association of nitrous oxide with AMH. And AMH levels were inversely related to environmental pollutants such as PM10, PM2.5, and nitrous oxide. What they found that they have a strong influence of nitrous oxide exposure on AMH serum levels. Although the genetic component is highly predictive for defining the ovarian reserve at birth, potentially modifiable environmental factors could influence the rate of decline in AMH and ovarian reserve during adulthood. So in this study, in Korean women, they compared the outdoor air pollution and diminished ovarian reserve. And they looked at the AMH ratio, which is defined as an observed to expected AMH based on age. And what they found that there was 3% to 10% decrease in AMH level with pollution. In cohort of infertile Korean women, there was a suggestive evidence of negative association between ambient PM concentration and ovarian reserve, highlighting the potential adverse impact of air pollution on women's fertility. Now, in this study, which was by Fatima et al., they also found inverse association between the pollution and AMH levels. And they actually found that the green space has an increase in serum level of AMH. So the findings supported a beneficial association of exposure to green space and detrimental association of exposure to air pollution with ovarian reserve. Now, what does BMI, or the weight and height ratio, has on the effect on the AMH? So in this study by Jaswa et al., the BMI was checked whether it is associated with AMH or not. And they found that increasing BMI and waist circumference were associated with reductions in AMH and AMH/AFC ratio. Increasing BMI was associated with reduced AFC in PCOS, but not otherwise in ovulatory controls. So they concluded that BMI was associated with increased BMI was associated with reduced AMH, and decreased AMH production by the follicle unit may be responsible for reduced AMH with increasing BMI. Now, in another study where they compared the association between body mass index and ovarian reserve, and they found that in decreased ovarian reserve, the mean random serum AMH levels were 33% lower in overweight and obese women as compared with women with normal weight. So overweight and obese women with decreased ovarian reserve, as defined by high day 3 FSH levels, have lower serum AMH levels and a number of oocyte retrieved compared with non-obese women with decreased ovarian reserve. Now, in this study, again, the relationship between the AMI and BMI was compared, and after adjustment for age, BMI with more than 25 was significantly associated with higher AMH values. So in this particular study, in fact, AMH was positively correlated with BMI, especially in patients younger than 35 of normal weight with normal ovarian reserve. The presence of mild excess adiposity seems to be associated with higher AMH values. So this data contradict the previous study showing a negative impact of excess adiposity on AMH serum. So we still don't have a clear-cut answer. We need more studies regarding the relationship between the AMH and BMI. Now let's look into some contraceptive, oral contraceptive, where we use the estrogen and progesterone. What do that has an effect on the AMH? If you look into this chart, you can see that the normal level of AMH, and then after 5 weeks of use, what happens? The AMH level goes down. And then if we look further at 9 weeks, the AMH level goes further down, whether it's in the form of pills or patches or the rings, whenever we use hormones. So in this study by Peterson et al., which was in 2015, they compared the oral contraceptives, whether it affects the ovarian reserve parameters or not. And what they found that the ovarian volume was 50% lower, and AMH was 19% lower, and AFC was 19% lower in oral contraceptive users compared with non-users. And what they found that there was a shift towards the smaller sized antral follicular subclass. In this another study, they also found that the users of hormonal contraception had 29.8% lower AMH concentration, 30.4% lower AFC, and 42.2% lower ovarian volume than non-users. So this study indicates that ovarian reserve markers are lower in women using sex steroids for contraception. So thus serum AMH and AFC may not retain their accuracy as predictors of ovarian reserve in women using hormonal contraception. What about vitamin D? Now in this study, they compared there were 30% were vitamin D deficit, and about 69.3% had normal vitamin. And the mean AMH and AFC levels did not differ significantly between the two groups. So they did not find any association between the reserve and vitamin D. There was another study that showed that low levels of vitamin D may contribute to the decreased ovarian reserve. So if we look into the various uses of AMH, of course, for the IVF treatment, we use it to check the ovarian reserve. We also look into the individualization, or that means we properly, so that we can use this level for proper stimulation. And the third is also it helps us to predict the success rate, better prediction when confronting with couples, especially in older women. Also, sometimes apart from the IVF treatment, we can use it for making diagnoses like PCOS, menopause, and in some cancers. So quantifying fertility, this is very important, and it has become very, it's a direct to customer testing services. And this is a study from US where they found that it is frequently branded as an egg timer or biological clock test. And the women are finding it very easy to use. They can go direct to customer testing. They don't need to even report to the gynecologist or normal physician. Very convenient. This can be used even for single women and as an alternative tool for family planning, particularly for LGBTQ groups and any individual. And if it is reduced, then they can even come forward for options like egg freezing if they're not planning pregnancy. Now, so the influence of AMH on IVF success. AMH is a useful parameter that should be measured before performing an IVF or ICSI. In younger patients, AMH do not predict pregnancy outcome, but in patients older than 36 years, AMH can be used as a prognostic factor. But for a woman's AMH, even if it is very low, she still has an acceptable chance of becoming pregnant. Now, IVF outcomes of women with discrepancies between age and AMH. So we often, when we do practice, we often found there is a discrepancy between the age and the AMH level. It has been noted by this study in Zhang et al. That the young low AMH level group showed a poor ovarian response, but a better clinical pregnancy rate and live birth rate when compared with the older with the higher AMH group. Now, AMH is used in other gynecological conditions like tumors and cancer. The higher concentration of AMH in tumors is due to enlarged granulosa cells, which release large amount of AMH into the bloodstream. Now, the same positive association of high circulating AMH with high risk for breast cancer has been found in breast cancer patients. Patients with Hodgkin lymphoma has lower AMH and lower ovarian reserve than healthy women. So in granulosa cell tumor, AMH levels are typically increased in 76 to 93% of women with granulosa cell tumors. And the elevation of AMH levels precedes the tumor recurrence by up to 16 months. So very well in advance. It can be an early marker for granulosa cell recurrence. Ovarian function after chemotherapy and radiotherapy, we all know it goes down. So AMH can be used to assess the recovery of ovarian function. And there was another study which is in cases of childhood Hodgkin's lymphoma, where the AMH can demonstrate a clear-cut dose-related fall in AMH concentration in relation to the number of chemotherapy cycles, as you can see in this diagram. The blue one is by a chemotherapy regime of ABVD, where initially pre-treatment blue one was this level. It went down with the 2 cycles of chemotherapy, and then again it picked up and it recovered. But another chemotherapy, which is red one, BEACOPP regime, there you can see it did not pick up so nicely. And this is the red one, which remained affected with the chemotherapy. Now, another very good use of AMH is prediction of menopause. So several studies have suggested that a single AMH measurement may be a good predictor to the onset of menopause in aging women. And correct prediction of age at menopause could open avenues of individualized prevention of age-related infertility and menopause-related conditions like cardiovascular disease and breast carcinoma. So there are various studies. Now, this study was by Tepman et al., where they concluded that the predictive capacity of mothers ANM demonstrated in a single study makes this marker a promising contributor to AMH for natural menopause prediction. But this was only one study. When we looked into the complete model, they did not find that the extremes of menopause age prediction is good. And they had a very wide prediction interval. So these markers clearly need improvement before they can be used for individual prediction of menopause in the clinical setting. Another study where again they checked whether the menopause prediction be improved with multiple AMH measurements. Since one AMH is not giving good prediction, whether the multiple AMH levels can they predict, but these results showed that the knowledge of AMH decline rate does not improve the prediction of menopause, and the use of AMH as a screening method for the timing of menopause cannot currently be advocated. Now, we all know that impact of ovarian surgery is there on the ovarian reserve. An AMH level we use quite often to predict how much surgery has affected the reserve level. It has been seen in this study that endometrioma group had lower AMH levels compared with other benign ovarian cysts. An age of serum AMH decline 1 month after surgery in the endometrioma group was larger than the decline in other benign ovarian cyst group. The preoperative AMH level showed a significant correlation, of course, with the patient age, but the rate of serum AMH decline was larger for bilateral endometriomas, and in fact, the rate of AMH decline after surgery in the subgroup of more than 7 centimeters was significantly higher. Now, there are some experimental still use of AMH, and one is in the maturation of oocytes in vitro. So in IVF, IVM, in vitro maturation, recombinant AMH could be used as a compound added for maturation of immature oocytes collected from patients in the IVF program. Now, Zhang et al. Found that the addition of 100 nanogram per ml of recombinant AMH to the IVM medium improves the quality of mature mouse oocytes, resulting in a better quality of embryos after in vitro fertilization. Now, of course, this is still an experimental and many more studies are going on. There is another uses at contraception. Administration of recombinant AMH in human ovarian tissue in vitro has been shown to suppress the initiation of primordial follicle recruitment, although another study claims supposedly. So AMH can be used as a way of reversible contraception to halt primordial follicle recruitment, with this delay the onset of menopause. As a contraceptive, AMH could prove invaluable in preserving the fertility of women with lower ovarian reserves at a younger age, as well as becoming a more natural and non-invasive means of contraception in comparison to currently available substances. So in summary, AMH has still emerged as a single best blood marker for assessing the quantitative aspects of ovarian reserve and managing ovarian stimulation. Some studies continue to demonstrate a helpful age-independent association of AMH with qualitative aspects of ovarian reserve, such as egg quality, live birth rate, or time to conception, but this association is weak to moderate at best. Now, clinical studies now support expanded clinical application of serum AMH testing, such as for the prediction of menopause onset, for monitoring of ovarian effects of medication and surgical procedures, evaluating the risk of variety of disorders such as PCOS, POI, or POF. But very important, that caution is required when interpreting a single AMH measurements, because biological fluctuations, surgical procedures, Medications like contraceptives, lab methodology can frequently lead to dramatic changes in AMH results within individuals. And there are some recommended steps to account for variability in AMH results, which include, and as this has been nicely put in this checklist, is number 1 point is use one lab, calibrated to outcomes. Avoid mixing and matching of AMH values from different labs and identify a reliable single source for testing, which both calibrates the results to the clinical outcome of interest and commits to updating the clinician if calibration of the result changes. Then utilize more than one ovarian reserve test. Avoid using a single serum AMH measurements alone to assess ovarian reserve. Incorporate other markers such as antral follicle count and or early follicular phase serum FSH. Identify exposure. So whenever you take history, identify whether the patient has taken medications, example, hormonal contraceptives or chemotherapy, or had surgery like ovarian cyst or endometrioma removal that can affect the AMH levels. Counsel patients. Prior to testing, verify the patient understands the directional nature of the information being provided by the AMH testing, and that in a subset of women, the test result may change substantially with biologic fluctuations. Consider retesting. If testing results leads to a life-changing decisions, or if the results are consistent with clinical scenario, or inconsistent with the clinical scenario, consider retesting. Many improvements to the management of women's health are possible through appropriate AMH testing. However, variability in AMH results can lead to clinically significant variability in AMH results. Making careful approach to the interpretation is essential. And with the above simple steps, a clinician can rapidly minimize the risk for incorrect interpretation. So with this, we will end this session. But if there are any questions, then I'm happy to take questions. So we do have few questions. And there is one question by Shatasal where he's asking that, is there any specific time of oral contraceptive pills? So whenever we take any history, I think it is important that if you're expecting a AMH result to be discordant with the history, then you please look into it that oral contraceptive has been taken or not. Now, the effect of oral contraceptive on the AMH level, on the on the reported AMH level, is transient, and there has been seen study where they have compared the AMH level in patients without oral contraceptive pills and also those who had stopped the oral contraceptive pill a year back, and they found similar. So the oral contraceptive pill with this transient lower level is only for some time, and then it is not for permanent. So now there is any role in DHEA? Yes. Now there are some studies where there is a role in DHEA where they can have more number of follicles and more number of oocytes retrieved. But again, we can't say that we have a very realistic increase in the overall clinical pregnancy success. So we can try it for 3 to 6 months, but of course we need to reassess whether there is any change in the antral follicle or any change in the AMH levels, and the quality is still not completely improved by the use of DHEA. So now someone is asking, can you please show the initial few slides? I think, yeah. So I think we'll share the recording, whoever Dr. I think it's Mr. Kawal name. We will share the presentation. Now, which lab method of AMH? See, you have to trust, which whatever your nearby lab is, and uh, take it from a reliable lab which maintains all the quality checks. But this is overall a global problem, and where internationally also there is still no clear-cut standardization. So if you get a report, and in just by seeing one report, please don't make a decision that, okay, if it's a low, I'm going to go for the donor. No, just look into it again, and if you feel that it is not matching with the patient's profile, then get it repeated, or look into other aspects like day 3 FSH, and or do a scanning yourself and see how many follicles you can see. So yes, there can be sometimes reports which are not matching with the patient. Then in that case, either repeat or use other markers. And of course the lab should be, if that lab is not good, then maybe go on to the another lab. So along with that, it's always good, to combine other biological markers. But yes, if you ask me one good test, then AMH is so far the best, with the best sensitivity and specificity. Okay, I think with this we will close this session. Thank you very much.